Good evening, everybody. My name is John King. I'm the president of the Education Trust and had the honor of serving as the 10th United States Secretary of Education in the Obama administration. Welcome to tonight's webinar conversation, How Can We Safely Reopen Schools in the Fall? Tonight's event will be interactive. And so it's being recorded and live streamed on the National PTA's Facebook page. Through Zoom, you'll be able to participate in the conversation using the Q&A feature that is pictured on the screen. If you have a question at any point during the presentation, you can type it there. I'll keep an eye on questions throughout the conversation and try to use those questions in the course of our discussion. We'll also have a couple of poll questions this evening to try to get a sense of the views of all the folks who are on this webinar. We also hope that you'll join the conversation via social media. We're using the hashtag #SafelyReopenSchools on Twitter. And here you see in front of you with a Q&A function on Zoom, the hashtag #SafelyReopenSchools. And you can also use the comment section on Facebook to engage. I want to thank all of the participating organizations that put tonight's event together. We have a strong representation of organizations that support parents, various education stakeholders who work inside of schools and school districts, as well as civil rights organizations like the Education Trust, my organization. So as we enter the discussion tonight, I want to make a few framing points. One, everybody at school, teachers, staff, superintendents, school board members, parents, and of course students want to be back in school. Everyone wants to be back in school physically in traditional bricks and mortar settings. However, everyone also wants to make sure that that happens safely. The safety of students, families, school faculty, and school staff has to be paramount as we think about this coming school year. Certainly school districts all across the country are right now engaged in planning for the coming school year. They are planning for all eventualities depending on the status of COVID-19 at the start of the school year in their community. As they do that planning, they have to be guided by the science, guided by the advice of public health experts. And that's why we're privileged tonight to have with us two doctors from the Infectious Diseases Society of America who are going to help us understand the best science on what school districts need to do to ensure the safety of students, teachers, and staff, as well as students' families. So we're joined tonight by Wendy Armstrong, Dr. Wendy Armstrong, who is affiliated with Emory University School of Medicine. And we're joined tonight by Dr. Tina Tan, who's affiliated with the Northwestern University Feinberg School of Medicine. We're privileged to have them with us. They're going to open with a short presentation, and then we'll dive into the discussion. Dr. Armstrong and Dr. Tan.
Well, thank you. Daryl, can I get the first slide here? Next slide, please. So thank you everyone for joining us this evening. This basically gives you an idea of some of the topics that we're gonna cover very shortly, and then some of the questions that you can ask regarding these topics. We know that there's general agreement across the medical and public health experts that the decision to reopen schools has to be based on the latest available scientific data, and schools really should not be forced to reopen in an unsafe manner. While we all recognize the many benefits of in-person learning for children, we must balance those benefits with the threat that is posed by COVID-19 in the school setting. And so what I'm going to do is talk a little bit about some of these topics. Dr. Armstrong will talk about some of these topics, and then we'll go on to questions. Next slide, please. So when you think about children and COVID-19, We know that children are less likely to be infected with COVID-19. And if they are infected with COVID-19, they're less likely to have symptoms or they only have mild symptoms. And this shows you the data regarding children and COVID-19 as of July 2nd. We know that children represent about 7% of all confirmed cases of COVID-19 in those states that are reporting cases broken out by age. This includes 49 states, as well as the District of Columbia, New York City, Puerto Rico, and Guam. There have been about 50,000 new child cases reported from June 18th to July 2nd, which represents a 43% increase in the amount of COVID-19 being seen in the pediatric population. Over the last couple of weeks, there has been a significant increase in the number of cases that are being reported in children between 10 and 18 years of age. And this is something that we're going to have to consider as we start to think about reopening schools. In 20 states and in New York City, children represented about 3% of the total reported hospitalizations, and children account for about 0.5% of all COVID-19 deaths. Next slide, please. So one thing which has emerged since the end of April, beginning of May, is the multisystem inflammatory syndrome in children, or MIS-C. This syndrome was first recognized in the United Kingdom and then was recognized here in the United States, starting in New York City, but then spreading all across the US. Basically, the cause of MIS-C is unknown, but we know that children can become seriously ill with this particular syndrome that can cause inflammation in a number of different organ systems. And this particular syndrome can be life-threatening, with the majority of children that have MIS-C requiring hospitalization, many in intensive care units. The symptoms that have been seen with MIS-C basically overlap with some other serious syndromes and diseases, including Kawasaki disease, toxic shock syndrome, and septic shock. These symptoms include high fevers, severe abdominal pain, nausea, vomiting, and diarrhea, body aches, trouble breathing, neck pain, rash, as well as bloodshot eyes and severe fatigue. And warning signs that should indicate to a parent that their child needs to be seen by a physician and to obtain medical care include any child that has trouble breathing, that complains of shortness of breath, chest pain, or chest pressure, children that develop confusion, children that have bluish lips and faces, as well as very severe abdominal pain. Treatment of this particular syndrome includes supportive care, much of that in an intensive care setting, as well as anti-inflammatories, example being steroids and intravenous immune globulin. Next slide, please. So this was a study that was recently published in the New England Journal of Medicine that basically looked at children from 26 different states that had MIS-C from March 15th to May 20th. There were 186 patients included in the study. And one of the things that was striking was very much like what is being seen in adults with MIS-C. A large portion of children with MIS-C are in the Hispanic and the African American racial groups. So in this particular study, 31% of the children were Hispanic or Latinx, and 25% were Black or African American. 71% of them had involvement of at least 4 organ systems. 80% required intensive care unit management, with 20% being placed on mechanical ventilator. And as of May 20th, 70% of these children had been discharged alive. About 30% were still hospitalized, and 4% had died. Next slide, please.
So thanks to Dr. Tan for that beginning. I'm going to sort of pick this up and talk a little bit about what we know about children and transmission, which is a critical question to try and understand or to help inform decision making about school opening. The problem is that as with much of what we'll tell you this evening, much is still unknown. What we do know, and Dr. Tan mentioned this already, is that multiple studies suggest that young children have lower rates of infection than older children and adults. We've pulled out a couple here to show you that data. One from Geneva, which looked at children in the age 5 to 9-year-old risk group, had a risk that was only about 32% of that of the risk that adults had over the age of 20. There was no significant difference between children between the ages of 10 and 19 and those between the age of 20 and 49. So once children were over 10 in this study, the percent that were affected by COVID-19 was similar to adults. In another study in Iceland, which has had the advantage of being able to screen a very significant percentage of their population, they again saw a similar finding. And that is that among children under the age of 10, just shy of 7% were positive. But in children over the age of 10, it was about double that, about 14% were positive. And if you looked at the curves in those over 10, the rate of positivity gradually increased from 10 years to 11 to 12 and so on until reaching the rate in 20-year-olds, which then approximated the rest of adulthood. So there did seem to be a difference between young children under the age of about 10 and children who are older and into their teen years. The question is, does that mean that there is less transmission from younger children? And I will say that this data is with a little bit of a caveat that there's very recent data just beginning to come out that is showing some higher rates of positivity in the United States among some children, among younger children. And the question is, are we now testing children more than we were, or are children now mixing more and not staying home as much? But these studies from Geneva and Iceland, I think, give us some of the best data that we have. Next slide, please. So again, to try and look at that question of do children transmit, there have been studies that have looked at family clusters of infection. And what they saw was that multiple studies have shown that children are the index case. And by that, I mean the first infected person in a family unit that then transmitted to other family members. That's the index case, the first infected person. And they found that children are the index cases in fewer than 10% of familial clusters. And that, again, like I said, has been replicated in multiple studies. You can see some of the references below. So that, again, suggests that perhaps children may transmit less. Then the next question is, well, does that mean that children have less virus? And there is, frankly, no clear evidence that that's the case. One study from Germany in particular showed that there was no difference in the amount of virus, COVID virus between any particular age categories, including children, that children appeared to have as much virus as adults. So we can't explain why some studies have suggested that children are less frequently the index case in clusters in families. Next slide, please. So how does that help us understand what to do with schools, and how will that change school dynamics? And again, we don't have a crystal ball, but what we can do is look at real life examples around the world where schools have opened up. And I think, again, we see mixed results, but perhaps with some clues. So for example, Denmark reopened schools to students in mid-April, and they showed very little impact on transmission in the community. The same was true in Finland. But very importantly, there were some strict regulations that occurred when these schools were opened. They were staggered by age, so they actually brought young children back first instead of older children, based on the data that we've already discussed. And they were very careful about all the things that you've heard discussed, like distancing in the classroom and so on. So in contrast, Israel reopened schools in May. And there has been a really well-publicized outbreak that occurred with 244 new infections among children and school personnel. 130 of those were at a single school. What's the difference here? Again, not entirely clear, but one difference was that Israel had surging virus at the time these schools opened, whereas Denmark and Finland had very low community viral transmission at the time that they proceeded to open schools. And so I think that may be an important clue for us to consider. In the US, when we look at other kinds of settings, we have seen in Texas as of July 6th, over 1,300 cases in over 800 childcare facilities, with 894 staff and 441 children involved. And in July, a camp in Missouri closed after 41 campers and staff were infected. 4 days later, there were 82 total infections reported. And again, both of these were in settings where community control of virus was not present. And so again, I think there may be some clues there. Next slide, please. So in addition to those unresolved questions, what has another sort of lightning rod has been, how distant do we have to have children from each other? Is 3 feet better, or is 6 feet better for physical distancing? And obviously that has enormous implications for you as you plan school openings, because that changes the capacity of a classroom. The CDC has recommended that students are spaced 6 feet apart when feasible. The American Academy of Pediatrics has recommended spacing as close as 3 feet may approach the benefits of 6 feet of space, especially when face coverings are employed and there are no symptoms. The Lancet Journal, June the 1st, published a review of 172 studies across 16 countries and 6 continents. They found the risk of infection by keeping a distance of 3 feet or more was 3% versus 13% with a distance less than 3 feet. So we know that 3 feet appears to be important. It remains, I think, unclear, and I don't think we have the guidance or the data to guide whether 3 feet or 6 feet is the magic number beyond that. Next slide, please. I do want to return to one point that Dr. Tan already made, because again, it has, I think, significant implications as you consider school openings. And that is one thing that we cannot forget, are that we see significant disparities in populations based on race and ethnicity. We have seen across the country that Native Americans have hospitalization rates 5 times that of whites, that Black and African Americans have rates that are similar 5 times that of whites, and that the Latinx population is 4 times that of whites. This probably has a lot to do with social determinants of health, with how well can individuals physically distance in certain populations, what percentage of the population are essential health workers that are back on the job and getting exposures, and what other sorts of factors, how much access is there to medical care, and so on. Rather than, and I certainly don't want to suggest or leave anyone with a suggestion that there is any kind of predisposition among these racial or ethnic groups towards COVID. Next slide, please. And so I think the health disparities have implications for equity as you think about opening schools and different school districts and maintaining equity between them. What we do know, and what I've alluded to already though, is that reducing transmission throughout the community leads to safer schools. That while there's a lot of focus on school opening, we cannot lose, we must stay laser focused on reducing transmission in the community. And that includes, not just for children, but for adults, masks and face coverings, physical distancing, hand hygiene, and ventilation. We must pursue evidence-based policies and protocols that are flexible and change as our understanding matures. Many of us who discuss COVID regularly begin our talks with the caveat that whatever we say today could change tomorrow as we learn more. I think we've all seen that as the epidemic has evolved across the United States and across the world. And that remains true today as it did a few months ago, although I think we have more certainty about some things. So this includes that evidence must inform opening and closing protocols, and decisions need to be made about what happens when cases are detected. And so a critical element for schools is access to public health expertise that is available to them locally to help with this decision-making on a community by community basis. So I'm going to stop there and open back up to Dr. King.
Thank you. Thank you both for that presentation. Let me dive in sort of where you left off, Dr. Armstrong. You talked about how there's more for us to learn. We've certainly learned a lot about this disease already, about the airborne nature of it, the way that it's mutated. What kinds of things do you expect that we will learn even between now and September, the start of the school year in many places around the country, although some places start in August? And what kinds of questions should parents be asking, particularly about how COVID is playing out in their community as their school boards and superintendents consider how they'll reopen school?
No, I think you just actually at the end of that touched on perhaps the most important thing that we need to understand in September, which we don't understand today. And that isn't necessarily new information about the virus. It is that we don't know now where the virus will be then. And I think understanding community spread or understanding the situation in your own individual communities is absolutely critical, and probably one of the most critical pieces of information to impact decisions about school opening in the fall. As I hope to point out, community spread or community rates really do appear to impact what we see when schools open. And places of explosive growth are probably not places where we should be opening schools live fully. So I think that, the question is, are we going to have new science in September? And I think we've learned some really, really important things over the last few months. And one of those is that masks work and that distancing and hand hygiene are critical elements that go with that. These are the tools we have to prevent transmission. And that's not going to change. We may see new mutations, or there's been a lot of discussion about how much virus is transmitted in the air versus by droplets. Honestly, that doesn't change things anywhere close to the degree that using masks, distancing, and hand hygiene changes things, and understanding community spread. Dr. Tan, you want to add to that?
Yeah, I mean, I think that's all extremely important. And I think the other thing that's really important to understand is that currently we're seeing a surge in individuals that are 10 years of age and older. And just remember that the transmission dynamics in kids that are over 10 sort of mimic that of adults. So, I think it's going to be really important that we stay very focused on what the COVID-19 case count is in that population in order to determine, is it going to be safe to open schools for individuals that are 10 and older?
Thank you. Dr. Tan, let me follow up with you. When we look at polling of parents, a lot of parents are very concerned about whether or not school will be safe for their kids. Certainly a lot of teachers and school staff are concerned for kids, for families, and for their own safety at school. And many people are worried that maybe they can't go back to school until there's a vaccine. How would you think about that? What are the prospects of there being a vaccine, and how would you think about the relationship between having a vaccine and the reopening of school?
So that's a great question. And unfortunately, September is only 2 months away. So we're not going to have a vaccine available at that time. And even if we did, you really need to have fairly good uptake of the vaccine in order for the population to have enough herd immunity to basically protect against COVID. So I think right now vaccine needs to be taken off the table, because we're just not going to have a vaccine at the point in time that we're considering reopening schools. I think what's really important, and what parents and teachers really need to consider, is the protocols that are put in place in the various schools to basically try and prevent the spread of COVID-19 in the school setting. So there really needs to be screening protocols put in place. There needs to be, emphasis on physical distancing, wearing masks, hand hygiene, things like that. And I really think that, parents really and teachers really need to ensure that these types of protocols are in place before sending a child back to school. The other thing which I think is really important is that we know that during COVID, there has been a significant decline in the rates of immunizations in all different age groups, especially in the pediatric population. And that's something that I think the school systems really need to focus on, getting the children up to date on their immunizations before school opens, because you don't want to have COVID and possibly influenza, since you're moving into the fall, and a vaccine preventable disease all occurring at the same time, because that would really be quite disastrous. Dr. Armstrong,
Let me
do you have
follow
any
up with you,
comments?
Dr. Armstrong, and ask, is there a standard that parents should be looking for? Is there a data point about the rate of transmission that parents should be looking for as a sign about whether or not it's safe? Is there a rate of access to testing, a speed of return on the testing, a contact tracing system? What's the standard folks should be applying when they're asking, is it safe for schools to reopen in my community?
I think it's really hard to give you an exact number. For example, like this rate in the community makes things safe and this doesn't. I think trends are really important. And so some states right now have very relatively small numbers of COVID disease, but they're rising quickly. And others have enormous numbers that are rising quickly. And I think rising quickly is a bad thing, regardless of sort of that total number. Similarly, so I think that what you want to see is significant reductions. You want to see a downward trend for at least a few weeks. And that would be the sort of thing that I would look for, rather than being able to tell you that there's a number that's magic. And I agree with all of those things that you said. Again, there's not an easy metric, but there needs to be access to testing. There needs to be a plan for the school. Who are they going to test, and when are they going to test? There needs to be a plan for contact tracing. And is there the manpower, whether that be volunteers or public health officials, but is there a plan for contact tracing? So it is about having access and having contact tracing, but seeing what those plans are, and realistically knowing that in that community that can happen.
When you think about the structure of schools, Dr. Armstrong, and the question of contact tracing, kids come into contact with a lot of adults at school. How should schools be thinking about minimizing that? How should they think about all the personnel in school, from cafeteria staff to school counselors to administrative staff, who are interacting with multiple students? It's not like they can be separated from any one part of the school. How should they think about those staff as well?
Yeah, no, I think that's a great question. And I think that there are sort of different answers for different staff. I think it's important to remember that the risk of getting COVID is related to both the time that you're, with somebody who's positive, and then the type of exposure. So we know, for example, that masks dramatically reduce exposure, but you still probably wouldn't want to stand in front of somebody for an hour and a half, with time in close proximity necessarily. So again, sort of time plus exposure. So as you think about we think a lot about teachers and eye protection and masks, which work. But how do you think about the custodians or the cafeteria workers or these other folks? And so I think you have to apply that in your head. So a cafeteria worker, for example, what's their exposure? Their exposure is face-to-face with a student to potentially offering a meal, which may be boxed in this setting or something. So simple things like plexiglass guard in between the student and that cafeteria worker, who will be standing there for some time handing out lunches, might be appropriate. A custodian is probably going to have less face-to-face time, but again, and so measures in addition to masks, for example, and hand hygiene may not be necessary. But a school counselor who may sit with someone for a long time, probably, again, you would want to be very careful about masking and hand hygiene and sitting 6 feet apart and so on for a discussion. I think another thing to think about that I have seen get forgotten in our hospital settings is we're thinking about our exposure to students, but we must remember exposure to adults. What do our custodians, cafeteria workers, and teachers do at lunchtime, for example? What are we doing in break rooms when you take off your mask to eat? And that is a setting where we have definitely seen transmissions occur, where people are in a more crowded area eating together and talking. And so that is a planning for how do you find spaces for people to eat during the day, who are the adults that are around children but may not be with them at lunchtime. Another thing to think through. This is where I think it's so important to have local advice that can guide you and to consider all the people in your building and all those events and what your plan is going to be.
Dr. Tan, how would you add to that?
So I think one thing that has been mentioned is that, you know, in order to try and minimize contact, that, you know, maybe students eat at their desk in the room that they're assigned to, and maybe students get cohorted with a teacher in that room to minimize walking through the halls and actually exposing other individuals, and have the teachers actually change classes if they need to change class, as opposed to all the students rotating and changing classes. But Dr. Armstrong brought up some very important points in that, you know, it's not only the students, but it really is the adults that they're in contact with that we also need to consider how we protect them and how we minimize their exposure or potential exposure to COVID.
Follow up, if there is a case, there are many schools that either don't have a nurse or have limited access to a school nurse. How should they manage the follow-up, the contact tracing, the precautions that might be necessary to make sure that student and the folks who that student has interacted with know what they're supposed to do to take care of their health? How should schools navigate that? What's the role of the community and community health providers in that?
So that's a great question. And that's something that is going to be a little bit of a problem, in that they need to let the public health department know that there's a case in the school. However, as you can imagine, there are many public health departments that just don't have the manpower to basically go through everything that needs to be done when a case is identified in a school. So it may be that we need to find volunteers in place of the school nurse to basically help with identifying those individuals, having contact tracing of, you know, the families and the other individuals that were in contact with the case. It's very, very difficult, and there really is not the financial resources available currently to basically have this done. And it may be that we have to get volunteer providers in the community to basically help with this if there is a case that is identified.
And I think this is a moment to, again, reinforce what you mentioned earlier, Dr. Tan, which is that cohorting kids so that they are in, you know, subgroups or subpopulations within the school makes this much easier, a much easier task. If your children are only around, you know, 6 or 8 other kids throughout the course of the day, that contact tracing challenge is a much easier challenge.
Yeah, and it does filter down to, you know, do you close just that class or do you close the school? Because closing the school is definitely a much bigger problem than if you basically, you know, take a class of individuals and have them not come to school for a certain period of time.
I know I'm asking the questions, not answering them, but I have to take this moment to editorialize that what you both described in the last few comments is an expensive set of activities that will require substantial resources from schools. Now, Congress earlier passed the CARES Act that provided about $13.5 billion for schools. It's not nearly enough to pay for the kinds of activities that you're describing. The Council of Chief State School Officers has projected that the need is somewhere between 150 billion and 250 billion to ensure that schools are in a position to do these things. And in many states, there's a risk that schools will be cut because of lost revenue due to the COVID-19 economic crisis. So I just want to acknowledge how costly this will be. I'm sure that all the school folks who are joining us are thinking in their head about the level of expense that's required here and the challenge that will present for school districts in this moment. We really need Congress to step up here, and hopefully they will do so in a next stimulus. But it needs to be at a level that will make this possible in many schools that are already under-resourced. Let me ask you about personal protective equipment. And in particular, Dr. Armstrong, how would you think about personal protective equipment for school staff? How would you think about it for students? There's been a lot of conversation about masks and students wearing masks, the challenges potentially of younger kids sticking with the mask. How would you think about that? And how would you advise folks on that?
You know, I think this is a big challenge. I think it's easier in an older school population, but in the younger population, this is definitely going to pose some challenges. Again, there's no question that masks work. And so to the extent that we can encourage children and help them practice and so on to wear masks and to implore our older kids to wear masks, it's critical. And I think a mask throughout the day, kind of helping remind, again, older kids will be much easier, but not to touch or fiddle with that mask multiple times a day or touch the front of it will be helpful and important. Eye protection is something that's helpful. Face shields can be helpful. And it's an opportunity, maybe face shields, to have a piece of personal protective equipment that, if a mask could not be worn, does allow someone to see facial expressions and so on. And so that adds an additional opportunity, I think, and some people find them less objectionable. I think this is going to be tough, but I think really emphasizing masks and or eye protection, particularly for our 10 and older kids who may be able to handle it better, will be critical. Dr. Tan, you have more pediatric experience than I.
Yeah, so we know that usually kids under 7 years of age, it is very, very difficult to get them to wear a mask all day long. If you can physically distance them so they are 6 feet apart and you kind of keep them apart, then maybe they don't wear mask at that time. But, you know, when they are closer together, you have to get them to wear a mask. And like when they're on the playground and you know that they're going to be outside and they're not going to be able to keep that 6 foot distance, you get them to wear the mask at that time. But maybe in the classroom, when they're sitting at their desk and the desks are 6 feet apart and the teacher has a mask on or a face shield on, then maybe they don't wear the mask at that time. Older kids, probably you really should try and get them to wear the mask at all times, if that's possible. But, you know, as Dr. Armstrong mentioned, it is very, very difficult. I mean, even adults can't keep the mask on all day long, so it's hard.
Yeah, it's 2 follow-up questions. Mask and face shield?
So it's kind of either or. There are certain situations where a special needs student might need to see a teacher's face. So for example, younger children actually, you know, in order to sort of interpret what they need to do, probably need to see a teacher's face. Kids that are deaf and lip read need to see a teacher's face, and many special needs children do better when they can actually see someone's face and see their mouth moving. So in those situations, a teacher can wear a clear face shield that allows for them to basically have their face out so that the student can actually see it. But at least a mask, if they don't have a face shield, they have to wear a mask.
Got it. And how would you think about the issue of ventilation, which is a sort of long-standing challenge because as a country we've underinvested in our school infrastructure. how would you think about ventilation? How should parents and school leaders assess the quality of ventilation in a building?
So we know that COVID-19 transmission occurs much more readily in crowded, poorly ventilated settings. It has been suggested that if it's available, that schools try to hold some of their classes outside, maybe, you know, on the playground under a tent, where there is better ventilation if weather allows for it. Open the windows in the rooms to try to ventilate the rooms better. But I know that's a challenge because there are many school systems around the country that are quite old. And so the ventilations in the rooms are definitely not optimal. And I think, you know, school systems are going to have to think about, you know, maybe changing the filters on their systems so that, you know, you have a HEPA filter that basically is able to filter out some of these particles. But in those schools that don't have air conditioned systems, if they can open a window, probably opening a window would be the best way to ventilate a crowded room.
Yeah, Safa, we have a lot, thank you, a lot of questions in the chat about masks and face shields and eye protection. So I want to make sure that we leave folks clear on this. There are some folks in the chat who are asking, would a clear mask be better than a face shield? There are other folks asking about eye protection and what that should look like. So can you weigh in a little bit on that as well?
So the face shield actually provides you with both eye protection as well as it would do what a mask would do, essentially, if the face shield sort of goes down below your chin. That way, you know, you have eye protection and you basically have what a mask would do. People have suggested that if you don't, or if you can't get a face shield, then you can try to wear goggles. I don't know how easy that would be to wear goggles and a face mask, but I think, you know, if you're thinking outside the box, that might be some way of protecting yourself. Face masks, a clear face mask or a face shield would definitely be really important in those situations where you have children who themselves are special needs and they can't wear a face mask, and they might have more secretions than other children. And I think in those situations, the teachers really probably should wear a face shield in order to protect themselves.
Dr. Armstrong, do you want to add anything on the personal protective equipment question?
No, and again, I think that the key is face covering, a face mask or a face shield. That I think that for individuals who are asymptomatic and we're not highly expecting COVID and so on, you don't need to worry about doubling, about having both. I think we're talking about a face mask or a face shield.
Got it. Thank you. Let me turn, before we turn to audience questions, and I think we're going to have a poll shortly as well. But let me try to get through a couple more questions. There are students who require services in one-to-one or small group settings, particularly students with disabilities. How would you think about the right protocols? In some cases, be very difficult for those students to really honor the 6 feet distance. How would you think about that? How would you want school districts to think about supporting their staff in those situations?
So I think in some of those situations, if you can get those kids to wear a face mask, that would be very helpful. I think in many situations, that's probably not something that the student can tolerate. Then I think you really are going to have to cohort them so that they're only around a small number of teachers and they're only around a small number of other children who might be able to wear a face mask and keep themselves protected. At least they would have some protection with the face mask on as opposed to no one having a face mask on.
Dr. Armstrong, you want to add anything?
No, I think Dr. Tan said it all.
All right. Let me come back to this question of when there is a case in a school or a set of cases. What should happen next? How should school districts decide how to proceed when they've had such a case?
So I think the first thing is recognizing the case, right? And so that is being sure that there are screening protocols, that there are messages home and to teachers and so on, looking for that symptomatic students should not come to school. And then if they are discovered at school, that they are very quickly sort of removed from a classroom setting and taken to another location to be evaluated. And so the first thing is limiting exposure and limiting the likelihood that that will happen. Of course, it will happen. And then in those settings, again, it's first getting the student home or out of the building. And then initiating a plan that needs to be specified in advance. There need to be protocols so that this is not made up on the fly. And that's a question that parents would want to know that the school has thought through. And that may include, again, quarantining a cohort of individuals that that the student has been in association with teachers, if that has been successful. School districts may choose to shut down the entire school, although again, if the cohorting is fairly strict, that would not necessarily be required, I think. But those are the sorts of plans that need to be in place.
Right. I think we have our first poll question. Give folks a second to respond to the poll question. All right, Dr. Tan, did you want to add anything on that question of what to do when there is a case that's been identified?
I think the thing that I want to emphasize is that that protocol needs to be in place before the school opens, because you don't want to find yourself in a situation where you don't have a protocol as to what to do when someone is diagnosed with COVID, and then everybody's kind of running around not knowing what should be the next step. So I think this is a protocol that really needs to be thought out very carefully and in place before school starts.
And would either of you have any recommendations for the broader community? Assume that the school follows up with any student or staff member who interacted with the student who was identified as sick. What happens for the rest of the school community? Does everyone come back the next day the same way? Are there special cleaning activities that should take place? How should the school district proceed?
So, I mean, I think with respect to the exposure with a student that's been identified, there are cleaning activities, but there should be cleaning activities really every day at school. Cleaning protocols are, again, one of those things that you want to know are in place in advance and occur on a daily basis, wiping down high-touch surfaces and shared instruments like computer keyboards and so on, desks, etc. So one would hope that the cleaning that is being done on a regular basis is enough. One might want to do an additional deep clean in that setting where someone where a positive case has been identified. So again, based on the plan that's developed in advance, the answer may be that, again, you quarantine a cohort of students, in which case the rest of the school after the cleaning that evening can come back. The other thing that is important to remember too is, what were the exposures? Was this a child that was positive that was never able to wear a mask and was around a number of other unmasked children? Or was this a setting where it was an older student and everyone was masked and 6 feet apart at all times. And that may influence decision-making as well. Those are the kind of nuances that I think individual communities need to be sure that they have a plan and have local experts help develop those.
So now here we have our poll results. The question was, how confident are you that it will be safe for students and educators if all schools fully reopen to start the 2021 school year? And as you could see, the very unconfident and somewhat unconfident account for the largest share, certainly of poll respondents, and that's more than 80% of our audience responded. Given that result, and given the high degree of anxiety that we have in our communities about school reopening, that I feel as a parent of 2 public school kids in Maryland, how would you think about this argument that folks are making that there's a trade-off, that there's a real harm to school being missed? Certainly the American Academy of Pediatrics has made this argument. How would you weigh that against the anxiety that many of us feel as parents about school not being safe?
I think it's an individual decision. And I think a lot of it is driven by what's known academically, but that we know that kids, especially younger kids, don't learn as well when everything is virtual, and they really need kind of the stimulation of in-person learning to basically develop some of the skills that they need. And that really has to be weighed against what the risks are for these kids to go to school in an in-person setting. But I think it's an individual decision that a parent needs to make as to whether or not they're comfortable sending their child to school, provided that the school has in place all the things that we talked about in order to try and prevent the spread and transmission of COVID-19 in the school setting. Nothing is going to be perfect, and we know that. But I think if the school systems do have protocols in place to protect the students and the teachers, and they think about not going to school in person all 5 days a week, but maybe it's a staggered schedule where there's, some virtual learning and some in-person learning, I mean, that may be the better of the situations to consider.
And I think if you have those pieces in place and are in a community where community spread is very low, then I think that school can happen very successfully. But there are other individual circumstances too that may lead a parent to not send their child back. And that might include, for example, who's at home with the family. Is there an elderly individual or an immunocompromised individual? And so those kinds of personal issues may also come to bear when parents are making this decision.
Thanks. Let me turn now to a few of the questions that we've gotten from the audience. One, young children, kids in childcare, for example, or pre-K, the 0 to 4 range. Any special considerations that communities should have as they're thinking about kids 0 to 4?
Even kids 0 to 4. I mean, obviously kids under 2 years of age are not going to be wearing a mask. We know that kids that young probably don't transmit as efficiently as adults would. So it's really going to be up to the adults to wear a mask, to basically try and social distance these children somewhat, and cohort these kids into small groups in a classroom so that it's the same 5 or 6 kids that one child is around, and the same teacher. That way you don't have exposure to a large number of kids or to a larger number of adults. And then obviously there has to be screening protocols in place for both the staff as well as the students. There has to be pickup and drop off schedules so that you don't have a crowding of a lot of parents and a lot of kids in the same place at the same time. There also has to be, protocols in place as to what to do if somebody were to test positive, very much like the school situation. But, because these are younger kids, it definitely is going to be harder for them to physically distance.
Dr. Armstrong, let me ask you, how would you think about extracurriculars? How would you think about sports, band, theater? How should school districts think about that? How should parents think about that as their kids asked to participate in activities outside of school?
Yeah, no, I think that that's going to be a very challenging area. And I think many of the things you just mentioned are areas where we have particular concerns. Extracurriculars that worry me, one is choral events. We have already seen outbreaks in choirs where the act of singing and that expels a lot of air and so on can really lead to rapid transmission among choruses or choirs. And so that is something that I think we probably are going to need to put a hold on in many places in the next year. Band instruments, again, I think a little bit challenging for many of the same reasons, whereas an orchestra doesn't have the same set of challenges. You can socially distance an orchestra and not have a lot of, a lot of extra heavy breathing and things like that. Same is true for sports. We've seen, again, outbreaks among teams that practice together. And again, you have people breathing heavily in close proximity, and that's a challenge. One can imagine if your sports team is golf, that may be a different, may not have the same risk, but most things are teams where people are exerting themselves together, and those are going to have some concern for sure. So I think it depends a little bit on what the activity is, but there are many areas I think of concern where social distancing is difficult, and there is either more exertion or more sort of air movement, personal air movement as part of that.
Thank you. Dr. Tan, how would you think about, maybe this is along the same lines, but how would you think about transportation, school buses, arrival and dismissal procedures when you're likely to have lots of students coming into the building at the same time?
So again, I think you're going to have to stagger some of that depending upon whether or not you're staggering your classes that are attending schools on different days. So what I mean by that is maybe you have your kindergarten through third graders go to school on Monday and Wednesday in person, and then you have your older kids go to school on Tuesdays and Thursdays in person, and then everybody is virtual on the other days. School buses are a challenge because you want to be able to physically distance children on the bus, and everybody on the bus needs to be wearing a mask, and the bus driver needs to be wearing a mask, and maybe have plexiglass around where the bus driver is so that he's not exposed to so many different people on a day-to-day basis. Also, you shouldn't have adults on the bus that don't need to be on the bus. So it might be the bus driver and 10 other kids that are spaced every other row. And there should be like assigned seating on the bus. But again, that's going to be really hard for some school districts where you have a lot of kids going to school and their major way of getting to school is by school bus.
Yeah, I mean, I think just this discussion brings back, this concern about equity as we think about opening schools, is that, schools with fewer resources, schools where people rely more on transportation, or schools that are more crowded and so on, really are at a little bit of a disadvantage here. And there needs to be funding and support in order for that to happen. And as you've already mentioned, Dr. King, that can't, school districts can't bear the burden of that. This really needs to be a national effort. But I worry about equity as we move forward and think about which schools will be able to open safely and which will require more resources and may get left out.
We're coming towards the end of our time. We have over 650 questions. So there's obviously a lot of interest in this topic. I want to ask a hard question. Maybe this is a hard note to end on, but I think it's important. A few weeks ago, I did an event with the Minister of Education from Finland. Now, Finland already went back to school before their summer break. But what she described was a national commitment to masks, to the public health procedures that you all have recommended throughout this conversation, a national commitment to extensive testing with prompt results and contact tracing and careful contact tracing, and a substantial investment in public education to ensure that school districts, that schools have the resources they needed to make it safe. And I found the conversation heartbreaking because of where we are as a country. So I'd love both of you to weigh in on, if we don't do the things at the national level and state level to change the context, where will we be by this fall as we add in folks being indoors, as we add in the traditional flu in addition to COVID-19? Where is this all headed if we don't do the things necessary?
Well, I think if we don't do the measures that, Dr. Armstrong and I spoke about, you're not going to be able to attend school at all. Everything is going to have to be virtual. And that in itself presents a lot of challenges, especially in those school districts that don't have a lot of financial resources. Because how do you provide computer access for every single one of those students? And not only it's the computer, but it's also the access at home. Who pays for that? How do you monitor, what these students are actually doing? Who's going to help them with their homework? I mean, that really does bring in a lot of other challenges, as people's parents really do need to go back to work in many instances in order to put food on the table. And, that's a really, really difficult question. But, if we don't put into place the protocols that we've been talking about, then you're not going to be able to attend school in person, because you're just going to have a massive outbreak of COVID-19 all across the nation.
And I'll add that, I think one of the really challenging things to think about is, if we go back to school and suddenly there's a school with 5 cases, the assumption is going to be that there was transmission in that school, but that may reflect the community and the fact that we aren't controlling our communities well. And I'd love to use this moment to sort of advocate, not only do we need a national plan for schools like you just outlined, but we need a national plan for everyone. I implore everyone to wear face masks and to get, if we can get community transmission under control, we can go back to school with a lot fewer dollars required to do that. But we, as the grownups in the room, also have to actually be doing all of these things. It can't be the schools alone. The schools can't exist as a perfect bubble in a community that is completely uncontrolled. And so, so I think we need financial resources committed to, and a national plan committed to getting us through this pandemic, and funding for public health infrastructure as well.
Yeah, the Infectious Disease Society of America actually has individuals all across the United States, and Amanda would be happy to help anyone who feels that they need to speak to an infectious disease person about some of these issues. She can put you in touch with them. But, as Dr. Armstrong said, I mean, there really needs to be funding for all of this if we're going to do this successfully.
We have our last poll question up now, which is, do you believe that Congress should allocate additional emergency COVID-19 relief funding to K-12 public schools before the start of the 2021 school year? Let me ask one last question before we come to the end. Advice for parents. I've tried to ask some of the questions from the Q&A, but we have over 700 now. But there are a lot of parents who are clearly struggling with what the right thing is to do and how to evaluate the plans that are being described by their school district administrators. Any closing advice for parents before we wrap up?
That's a really great question. That's not easy to answer. I think at the very least, there probably needs to be some way for the school to track the community spread of COVID. And if there really is a surge in the number of cases at the time that school is going to open, that you don't open the school. There has to be a protocol in place for screening both staff and students that will be going to school. And there definitely has to be a protocol in place for what happens in the event that there's a positive case. And that's in addition to social distancing, wearing masks, hand hygiene, frequent cleaning of surfaces, whether or not you're going to stagger the school attendance by grades, cohorting kids in different classes, cohorting teachers for different classes, things like that. But those things have to be in place before a child should go to school.
So I think that's what parents can do, is they can ask for that transparency. And if a school can't offer that transparency, they're probably not prepared to bring students back. And so the tiny details about, the exact number of kids in the classroom per square feet in the classroom or something may not matter as much as a clearly thought out and thoughtful plan that somebody can tell you that answers all the questions Dr. Tan said. What's your protocol if someone's positive? What's your protocol for screening? What's your protocol to diminish exposure when the kids are at school? Do you have cohorting plans? Some very simple questions where, the fine details of the answers matter less than that there is a thoughtful plan that addresses it.
Thank you. Well, we just got our poll result. 98% of our respondents think Congress needs to act to provide additional funding. Amen to that. Hopefully Congress will act quickly in the next couple of weeks here on a stimulus bill that addresses both the educational issues and the public health issues that we've been talking about. It's up to them to put us in a position where we'll be able to make the country safer going into the next school year. I want to thank both Dr. Tan and Dr. Armstrong for sharing thoughts with us, for your very clear responses, for taking on some hard questions where the evidence isn't yet entirely clear, and you've provided us with the best science that is available today and pointed us in the direction of not only what school districts need to do, but what we need to do as communities, from mask wearing to putting in place the necessary testing and contact tracing, to the cleanliness, to the paying attention to ventilation, to the procedures around physical distancing in buildings. So thank you for sharing that. As we come to the close, I want to thank all the organizations that partnered to put this evening's conversation together. This is an incredibly challenging moment for education in America. There are, in fact, really no good choices here, just harms to weigh to sort out the path forward. In my own school district, Montgomery County in Maryland, the school district has decided to start online with everyone, and then to figure out how the public health situation evolves to determine when they can begin to come back in a hybrid form. And I appreciate that they are thinking carefully about how do they ensure that they keep kids safe. I also want to underscore something you both talked about, which is the equity issues that underlie this conversation. We really are in the midst of dealing with two public health crises, the public health crisis of COVID-19, and then the long-standing public health crisis of systemic racism that has been with us since the beginning as a country. We're grappling with that every day as we see the protests after the murder of George Floyd and so many others. And we know COVID-19 has had a disparate impact, as you showed in the slides, on Black and Latino communities, a disparate health impact, a disparate economic impact, a disparate educational impact. And so we've got to be vigilant as a country as we respond to the COVID-19 public health crisis, that we also are intentional as we respond to the public health crisis of systemic racism, and that we center equity in our conversations about how we move forward, and we direct resources to the places that need them most. Thank you again, Dr. Tan, Dr. Armstrong. Thank you again to our partners for making tonight possible. Thank you to all who joined us. The National PTA will post the recording of this event on their Facebook page. Many of the partners will also post the recording of the event. There'll be a transcript posted of the event, and the slides, which were shared in the Q&A, will also be posted. So thank you again for joining us all tonight. I wish everyone here tonight good health, good safety, and a good school year in whatever form it takes, because kids will learn next year. Maybe distance, it may be hybrid, it may be in person, but we've got to make sure we have a school year in which kids' academic and socio-emotional development continues. Thank you all so much.
Thank you.
Thank you.